I just went down the middle and say 200, but the total number of compounds in the plant is close to 400. There are polyphenols and flavonols and lignans and all kinds of other compounds that are there, and the hemp plant does not have, when I say anemic, I mean that the number of compounds in the hemp is considerably less. And as has been mentioned by several others, the hemp and the cannabis itself can absorb heavy metals and pesticides and other compounds from the soil. So since the CBD content is not very high in the hemp, they have to use many more plants to get the amount of CBD that's going to be a medicinal dose, and that means more and more concentration of potential contaminants. So CBD is not as desirable for me. And we must use laboratory medicine because I like to create a protocol based on milligrams of THC and milligrams of CBD, just like any other medicine that a physician would prescribe. You wouldn't say you couldn't prescribe a medicine if you didn't know what was in it and how much was in it. So I think the laboratory tested medicine is essential. And Stuart has talked about the various solvents that are used to extract the cannabinoids. I think that the potentially healthiest solvent is ethyl alcohol, and it also preserves the most terpenes. CO2 can make a good extraction, but I think you lose more terpenes with CO2 medicine. That's not to say that CO2 medicine won't work. It's just that alcohol may provide a broader profile of medicine. So here's an example of a tumor, Kaposi sarcoma, which has two references. One is from 2007. The other, I think, is about 2010. That shows that CBD is going to kill those tumor cells. So why would anyone with this particular tumor, this is a unique example, and also in this second study, even doses of THC may actually stimulate this particular tumor in this study. So if I believe it's important to use some THC to keep the endocannabinoid system activated, but with Kaposi sarcoma, if I haven't treated a patient with this particular sarcoma, but if I saw a patient who came to me to use cannabinoids to treat this type of tumor, I would probably use somewhere between 5 and 10 times more CBD than THC. I would use a small amount of THC to make sure that I activated the endocannabinoid system, but I would rely heavily on the CBD to do the dirty work, and I would make sure that there would be no antioxidants in the mix. So those providers of medicine that give the same cannabinoid profile to every single patient with every single cancer would probably fail with their regimen, whether it be 3-to-1, 4-to-1, or 5-to-1, are like the original Rick Simpson oil, not even laboratory tested, but not going to have very much CBD if just a common cultivar of cannabis were used, would probably fail with this particular tumor. And I'll show you later that different sarcomas have different research showing different cannabinoids to be most effective. So here's cervical cancer, which is an HPV related tumor, and we know from other research that the HPV is more sensitive to cannabidiol. So it's not strange or a surprise to see that there's a recent 2016 article talking about the benefits of cannabidiol for cervical cancer. Now here's a list. I don't think you can read it very well, but this is a compilation that I was able to find that had all of the tumors that were known to be associated with ID1. But it's not a complete list, and you have to search. If your tumor is not on the list, you have to do the search in PubMed and Google Scholar that I mentioned at the very beginning of the presentation. So here's some additional references on ID1, and I provided the slides. I don't know if you have them as a handout or not. No, okay. Anyway, so there are additional references that I provided that show the benefits of ID1 and its association with CBD and HPV and ID1, and the interaction of CBD and THC at the CB1 and CB2 receptor, and the article that shows how the cytochrome P450 interacts with cannabinoids, primarily cannabidiol. So this is one of the best current reviews. Actually, it is the best current review of anti-cancer mechanisms of cannabinoids, and we're fortunate to have one of the authors in the audience today. She's doing, it's the work that Cristina Sanchez and her group and others like her are doing that paves the way for me to do what I do. I couldn't do what I do and say that what I do is evidence-based if there weren't researchers like Cristina who are generating the evidence. Even though it's not clinical trials, which we all want, it's the best that we have. And to not use that research in designing a therapeutic protocol, I think would be a form of malpractice for anyone who provides the medicine and isn't utilizing the research. You can see that some of the papers that I've shown you so far have provided the evidence that you have to individually create the protocol. So here's the list of terpenes that have published research showing that they have anti-cancer activity. And you can see it's a list of the usual suspects there. Most of those terpenes are names that we're familiar with, and although today it's not always possible to create a protocol that includes the terpenes that we want, I think that the evolution of cannabis medicine, at least for cancer therapy, will eventually be that the prescription that we create will have how much THC, how much CBD, maybe other cannabinoids, maybe THCV will be part of the equation at some point, and then we'll be able to select cultivars of cannabis that have or have been bred to have higher levels of these anti-cancer terpenes. So we'll be able to use the full spectrum of the plant with more efficiency than we do today. So you have to have a reliable, consistent source of medicine to start incorporating the terpenes into the protocol. Currently, I use THC and CBD interchangeably between cultivars. In other words, if I were getting my CBD from AC/DC, I would not make that different than the CBD that I'm getting from a Bacchus, say, another cultivar that is high in CBD. And the same with THC. Some cultivars are broadleaf and some are narrowleaf, previously called indica and sativa, respectively. But the THC in both classes of those of cannabis have THC, and I use them interchangeably. So some patients will prefer a more stimulating cultivar first thing in the morning and a more sleepy cultivar at bedtime. And the THC content is what determines how much of each of those cultivars they take. And as I say, I use the THC independent of where it came from, independent of the cultivar from which it came. So last fall, I had a neuroblastoma patient. I never treated a neuroblastoma before, so obviously I did my literature search to find out what protocol to use, and I'll just give you an example of how the literature search can be invaluable in choosing the therapeutic ratio, the protocol that's actually be recommended for the patient. So when I came across this article and I saw that Raphael Mechoulam was one of the authors, it immediately got my attention, and I knew that was going to be an article that I was going to find useful. I was hoping to find useful. Anyway, in this study, let's just look at the bottom slide here. You can see that they treated the neuroblastoma cells in vitro in a petri dish, and you can see that the THC, CBD, THC, CBD. So this is the cell count, and you can see in this case both CBD and THC have the ability to kill the neuroblastoma cells. This is percent viability. So with the CBD, there was the percent of viable cells after 24 hours was pretty low, much lower than when THC was used. But when the medicine was extended and used for 48 hours instead of 24, you were able to reduce the number of viable cancer cells even further. So this told me that for this child with neuroblastoma, I was going to be using more CBD than THC. So with this kind of evidence, I can feel comfortable prescribing or suggesting. I can't prescribe cannabis. It's a Schedule I drug and has no medical value, and I can't prescribe it. But I can suggest to patients that it might be most helpful to take 1 part THC to 3 parts or 4 parts CBD. So that is an example of how doing a little bit of homework can hopefully save your patient's life. And here's just a picture, and you can see in this one, in the middle panel, they had 15 micrograms per milliliter concentration of CBD, and you can still, the dark blue spots